Hi, I'm Anthony Mato from Memorial Sloan Kettering Cancer Center. Happy to be here to discuss Richter's transformation. Richter's transformation is, of course, one of the more dreaded or concerning complications of CLL. This is when the disease can turn from an indolent lymphoma essentially to an aggressive large B-cell lymphoma or Hodgkin lymphoma variant. The literature is peppered with articles really discussing that this can portend a poor prognosis for patients with CLL when this event occurs. And I think what's most telling are guidelines like NCCN, where there is no clear standard of care for how to manage this problem, and clinical trial always seems to be the recommendation of choice. When this event occurs, most commonly it is the large cell lymphoma, and people spend a lot of time trying to think about whether or not this event is clonally related or unrelated to the CLL clone. This is very important because a clonally unrelated lymphoma probably has a similar prognosis as diffuse large B-cell lymphoma that occurs de novo and is potentially curable with anthracycline-based chemoimmunotherapy combinations. The standard of care in many instances has been to provide R-CHOP, which has been extrapolated from the DLBCL literature. More recently, Matt Davids has presented some exciting data looking at the combination of R-EPOCH with venetoclax, which does seem to produce more durable remissions and does seem to produce higher response rates than we've seen with R-CHOP chemotherapy and pretty well tolerated. So that may become a standard option. One of the major hurdles to any of these regimens that I'll mention is how to design a clinical trial to get an approval in this space, which is not that easy to do, particularly with this patient population. So maybe an advance is adding venetoclax to anthracycline-based chemotherapy. Once you've progressed beyond that, then really clinical trial is the best option in all circumstances. And some exciting molecules that have been developed over the last few years that are showing promise are immune checkpoint inhibitors like pembrolizumab or nivolumab alone or in combination with a targeted therapy. At the most recent ASH meeting, I presented a triple combination therapy called DTRM-555, which looked at a novel BTK inhibitor with pomalidomide and everolimus given together for patients with relapsed refractory Richter's transformation. There's also some exciting, very preliminary data on the non-covalent BTK inhibitors like LOXO305 or RQL531, which in small number of patients, less than 10 patients in each data set, have shown more than the majority of patients have responded. And of course, the other area where we're starting to see some promising data is cellular therapies, and CAR-T are now being used off-label in many instances for treating Richter's, and we'd like to see some combined data sets to give us a sense of activity and durability of response. And there are also some data sets emerging or discussing the role of allogeneic stem cell transplantation. So the most important aspect of Richter's transformation is to try to study it as its own entity, to not always extrapolate data from the diffuse large B-cell lymphoma de novo patient population, and then to try to understand how its biology is distinct either from CLL or DLBCL to try to tailor therapies for that particular patient population. I'll end by noting that although the prognosis has been poor, there is a lot of hope with these new classes of therapies. And fortunately, this is a complication that only occurs in 5 to 7% of patients with CLL. So thank you so much. Again, Anthony Mato from Sloan Kettering Cancer Center, and looking forward to having future conversations.